Welcome to today's HealthLine Innovator webinar from the American Association of Kidney Patients, titled Understanding the Impact of Secondary Hyperparathyroidism in Kidney Disease. Thank you for joining us today. My name is Jerome Bailey, AAKP's Director of Patient Engagement and Advocacy, and I'm pleased to lead today's webinar. AAKP is pleased to launch our Innovator webinar series, an extension of our normal HealthLine webinar programming. The content of this program, as presented, and sponsorship support of this webinar is provided by OPKO Renal, a division of OPKO Pharmaceuticals. As the oldest and largest patient-led kidney patient organization in the U.S., AAKP is proud to host its Innovative webinar as a service to the expanding national and global communities of patient consumers and their families, medical practitioners, researchers, and policymakers following innovation and advancements in kidney care and treatment. AAKP is an aggressive supporter of innovation to change the status quo kidney care. While this activity is an approved educational and informational webinar containing branded content, AAKP does not endorse specific commercial entities or products. Thank you again, OPKO Renal, for supporting today's program. AAKP's HealthLine and HealthLine Innovator webinars fall under our Center for Patient Research and Education. We believe patient and care partner education is an integral part of an individual's treatment, and to that end, AAKP is a champion for full patient care choice, the protection of the patient-doctor relationship, and the elimination of artificial barriers and government determinants of health that impede patient care choice and access to available treatment options. At AAKP, we work to ensure that patients have a central role in the research and development process so that unmet needs are identified and unique patient insights and lived experiences fully inform innovation and the product development lifecycle. This includes clinical trials to regulatory action and payment decisions. Through our initiatives, we aim to make sure patients have a central voice in research and innovation. By leveraging lived experiences and unique insights from the kidney community, we help drive meaningful advancements across the entire product development lifecycle, from clinical trials and regulatory processes to payment decisions. As medical science progresses with personalized medicine, cutting-edge technologies, and novel treatments, the potential for better outcomes in kidney care has never been greater. Today, we are focusing on a topic that is critically important to patient health and quality of life: managing secondary hyperparathyroidism. A significant portion of people with chronic kidney disease experience secondary hyperparathyroidism, which is when the parathyroid glands release too much parathyroid hormone due to chronic kidney problems, leading to weak bones and calcium buildup in the body. The prevalence of secondary hyperparathyroidism can increase as kidney disease progresses. In CKD stages 3 and 4, it's estimated that 40 to 80% of patients may be affected, and in patients with end-stage kidney disease who are on dialysis, the prevalence is even higher, with some studies reporting nearly 90%. Before we get to our speaker, we'd like to take a few minutes to share some powerful insights about secondary hypothyroidism we gathered from individuals like you ahead of today's event. To kick off today's program, I would like to introduce AAKP's Vice President and Chair of Policy and Global Affairs, Paul Conway. Paul is a passionate advocate for patient-centered care, patient participation in true shared decision-making, and the use of patient insights in kidney research. As a kidney disease patient himself for 47 years and a 28-year transplant recipient, he has been recognized for his advocacy work with several national awards, including the President's Medal from the American Society of Nephrology. Paul has served in 4 U.S. presidential administrations, including as Chief of Staff for the U.S. Department of Labor. He was selected by the FDA to serve as the inaugural chair of the FDA's Patient Engagement Advisory Committee and has served on the American Board of Internal Medicine Nephrology Specialty Board, as well as multiple CMS technical panels related to dialysis quality improvement measures. Through AAKP's Center for Patient Research and Education, we conducted an independent flash survey to better understand what people living with secondary hypothyroidism are really going through and how it's affecting their overall health and daily lives. Paul is here to share the result from the flash survey. Paul, I'll hand it over to you.
Thank you very much, Jerome. AAKP is very happy and pleased to have Jerome Bailey on our team because, as all of you know, Jerome is a lead for our programs. But most importantly, Jerome is a very empathetic person and understands the unmet needs of patients and the burdens that we each face as we go through our daily lives trying to manage a very tough disease. Secondary hyperparathyroidism is a major issue for patients, and access to timely therapeutics is very important, and thus today's webinar. As Jerome mentioned, we went out to patients to get their insights. This is important evidence for policymakers and for the media and for fellow patients to understand what the unmet needs are and the interests of patients in regard to secondary hyperparathyroidism and timely treatment. So let's go ahead and walk through the slides. In the first slide, you can see that we reached out to a fairly wide audience and that the understanding of secondary hyperparathyroidism is mixed. The majority of folks know a little bit about it. Some more know a lot about it. But you can see it's not something that is widely known throughout the community. And in terms of how it impacts somebody's health on a daily basis and how it can impact how they are trying to maintain a job and a living, it's also very important because you can see here it's also a mixed story. And sadly, about 20% of the folks have never been told about it. Another 32% of folks only know a little bit about it. That's a knowledge gap that we think is a huge barrier to patient understanding for what treatments are available and what questions to ask. So we asked how many folks had been diagnosed formally. About half of our respondents had been diagnosed with it. Over 30% had not, and those who were not sure, 19%. Again, as you'll take a look at and listen during our webinar today, we're very focused on the populations that know nothing about this or who are uncertain. So we asked, did a healthcare provider explain how secondary hyperparathyroidism affects or relates to the kidney disease? And you can see here that 41% of the folks did not get that type of explanation. 38% got a brief explanation about it. In terms of yes, clearly, 11%. This is very important because, as Jerome mentioned, AAKP fights for patient care choice and innovation. But if people don't know the questions to ask about how a condition impacts their kidney disease or their life, then they're unprepared to ask and drive for choices in their treatment. So we asked if folks had had their parathyroid hormone levels checked. About 84% indicated yes. We asked folks if they or their loved one had heard of any treatments specifically for secondary hyperparathyroidism. Over a third had not heard of any specific treatments. Some had heard of prescription medications, a little more than 20%. Some had heard of activated vitamin D, like calcitrol or paracalcitrol. And 15% approximately were unsure. Others were looking at over-the-counter therapy. As you can see here, it's a mixed bag in terms of treatment and preparedness of patients to ask for what types of treatments are available. We asked if you or your loved one had ever been offered a treatment specifically for secondary hyperparathyroidism. A little more than a third said yes. Over half said no. Unsure, about 11%. Again, keep in mind this figure of no. So these are patients with a known condition that are not being offered a treatment when treatments exist. We asked if you or your loved one was taking vitamin D supplements and what was the reason your doctor gave you. And you can see here that it's a very mixed kind of a picture in terms of vitamin D supplements. But again, drawing the connections with vitamin D supplements and treatments for hyperparathyroidism is not clear to the patient community. We asked if doctors had ever recommended a blood test to check calcium levels because they were concerned they might be high. 69% said yes, 16% said no, 16% were unsure. In treating secondary hyperparathyroidism, doctors often use nutritional vitamin D to raise vitamin D levels and active analogs to help lower PTH. So we asked patients if there were a single treatment option that could support both goals. Would that be something they'd be interested in discussing with their doctor? This goes directly to the issue of reducing patient burden and medications. Not surprisingly, 82% of the respondents said they'd be interested in it. Another 18% weren't sure. The unsure number here is fairly consistent throughout it, but again, that's an indication to us that a lot of patients simply don't have the basis of knowledge to understand their condition or potential treatments. Finally, we asked how important is it to you or to a loved one to have access to the most up-to-date treatments for secondary hyperparathyroidism? Not surprisingly, 78% said it's very important. 13% said it's somewhat important. Nobody said it was not important. So before we toss back over to Jerome, let me just make one very important point here. Patient access and patient care choice is a principle that AAKP has strongly fought for consistently. We've fought for innovations. We've fought for innovations for every type of condition that a kidney patient may encounter, including secondary hyperparathyroidism. The fact is that innovations have progressed. There are treatments available, but patients need the basis of knowledge to start asking the questions and demanding access to timely treatments. This is important to us. We hope it's important to you, and we hope this webinar helps inform you and your fellow patients of what they need to be prepared for to understand the consequences of hyperparathyroidism and the treatments that they have available to them. So, Jerome, nice job. Back over to you. Thank you very much.
Thank you, Paul. These survey results give us a roadmap for what patients value most and where healthcare providers and advocates like AAKP can help fill the gaps. It's now my pleasure to introduce Dr. Akhtar Ashfaq, Senior Vice President of Clinical Research and Development at OPKO Pharmaceuticals. Dr. Ashfaq has over 15 years of clinical experience and is leading the development of innovative treatments for chronic kidney disease, including Rayaldee and Afrin. Previously, Dr. Ashfaq held senior roles at AstraZeneca and Amgen, focusing on CKD therapies. His expertise in early intervention studies is invaluable, and today he will share insights on critical research aimed at improving outcomes for CKD patients trying to manage hyperparathyroidism. Please join me in welcoming Dr. Ashfaq. I turn things over to you.
Jerome, thank you so much, and thank you, AAKP, for this opportunity to present the advancing the treatment of secondary hyperparathyroidism and chronic kidney disease. These are my credentials. This is the overview of my presentation. I will be talking first about important safety information. Then we will dive into secondary hyperparathyroidism and chronic kidney disease, vitamin D treatment options for secondary hyperparathyroidism, Rayaldee for secondary hyperparathyroidism in stages 3 or 4 chronic kidney disease, Rayaldee's access and affordability, and in the last, I would summarize my presentation. Rayaldee is a treatment for secondary hyperparathyroidism in adult patients with chronic kidney disease stage 3 or 4 and low vitamin D levels, meaning with vitamin D levels, meaning the vitamin D levels have to be below 30 nanograms per ml before starting Rayaldee. Important safety information. Before starting Rayaldee, the level of calcium in your blood should be in the normal range. That means below 9.8 milligram per deciliter. Your doctor can tell you if your calcium level is right for starting Rayaldee. Rayaldee can cause hypercalcemia and hypercalciuria, meaning high levels of calcium in the blood or urine, respectively. You should tell your doctor if you are taking any other medications, including other vitamin D medications, either prescriptions or over the counter vitamin D supplements. Your doctor may tell you to stop taking them while you're taking Rayaldee, as very high calcium levels due to high vitamin D levels could cause severe changes to your heart rhythm or seizures and require emergency treatment. Tell your doctor about any and all medications you may be taking. While you're taking Rayaldee, tell your doctor if you receive any prescriptions or start any new over-the-counter medications. Also, tell your doctor immediately if you experience any of the following symptoms of very high calcium levels, meaning feeling tired, difficulty thinking, loss of appetite, nausea, vomiting, constipation, increased thirst, increased urination, weight loss, or any other abnormal symptoms or side effects. While you're taking Rayaldee, your doctor will order laboratory tests to see how your SHPT is doing. These lab tests will also examine your blood levels of calcium, phosphorus, 25-hydroxyvitamin D, and parathyroid hormone. Based on your test results, your dose of Rayaldee may be changed or stopped until your lab results improve. The most common side effects of Rayaldee reported by patients in clinical trials were anemia, infection in the nose and throat, high levels of blood creatinine, shortness of breath, cough, congestive heart failure, and constipation. Take your Rayaldee at bedtime and swallow your capsule whole. Do not bite or chew them. If you miss a dose, take Rayaldee at your next scheduled time. Do not take an extra dose to make up for the dose you missed. Be sure to follow your doctor's orders, including getting your laboratory tests done on time. If you have any questions regarding why you are prescribed Rayaldee, please speak with your doctor. If you have any questions regarding the support program offered by OPCO Connect, you can call the number on the screen. If you have the question regarding Rayaldee or the disease state it is designed to treat, you may contact the Rayaldee clinical pharmacist. You are encouraged to report side effects to US Food and Drug Administration, FDA. The website address and the phone number is on the slide. You can also report to OPCO Safety at safetyreporting@opco.com or the number on the screen. For more information about Rayaldee, please contact OPCO Medical Information. The number and email addresses are on the screen. Please also see full prescribing information available at www.rayaldee.com. Secondary hyperparathyroidism and chronic kidney disease, that's what we are here to discuss today. But before we dive into Rayaldee, we just need to speak for a minute on chronic kidney disease, which is now a global crisis. 850 million people are affected by chronic kidney disease worldwide. Just in US, 1 in 7 adults, meaning 36 million people, have CKD and half of them have CKD3 or higher. Contrary to popular belief, 66% of people with CKD are below age 65. And the sad part is that 90% of people who have chronic kidney disease don't even know if they have CKD. SHPT is a major complication of chronic kidney disease. Hyperparathyroidism is a condition that causes your parathyroid glands to make too much parathyroid hormone, also called PTH. Parathyroid glands are 4 small glands in your neck that makes parathyroid hormone, and they are called parathyroids because they are next to your thyroid gland. So what happens that as kidney disease progresses, kidneys start to make less vitamin D hormone, and that results in low calcium levels in the blood. To normalize blood calcium levels, parathyroid glands start to secrete PTH. Even though by secreting more PTH, parathyroid glands are trying to do a good thing by trying to normalize blood calcium. But in the process, it causes what you can say a collateral damage. For example, high PTH is associated with bone disease and fractures. It is implicated in cardiovascular disease and leads to faster progression of kidney disease. Unfortunately, it is a silent killer just like high cholesterol. Patients don't develop symptoms until the disease is far advanced, and at that time, the symptoms of SHPT, which may be non-specific, starts to appear, and they may include weak or broken bones, bone or joint pain, kidney stones. Patients may start urinating more than normal, stomach pain, feeling weak or tired, feeling sick to your stomach or throwing up, feeling less hungry than usual, meaning loss of appetite. As we discussed in the previous slide, patients with SHPT are more likely to have low levels of active vitamin D. Active means the form your body can use. When your kidneys produce less active vitamin D, the body has less calcium available for use. Vitamin D plays a critical role in preventing and managing secondary hyperparathyroidism in patients with CKD by regulating parathyroid hormone levels, blood calcium, and phosphorus balance. So, what are the treatment options for secondary hyperparathyroidism? There are three different vitamin D options for secondary hyperparathyroidism. Nutritional vitamin D supplements, meaning cholecalciferol or ergocalciferol. Cholecalciferol is a vitamin, it's an animal-based product, and ergocalciferol is a plant-based vitamin D. Active vitamin D, meaning calcitriol or rocatrol, pericalcitol or Zamplar, and Rayaldee, which is extended release calcifidiol. Nutritional vitamin D supplements have limited ability to correct vitamin D insufficiency, especially in overweight and obese patients. And even if vitamin D levels are raised around 30 nanograms per ml, they are usually ineffective in lowering PTH. They are also not approved by FDA for the indication of treatment of secondary hyperparathyroidism. And KDIGO, which is the global guideline organization, has mentioned in their 2017 guideline that the effectiveness of nutritional vitamin D supplements is unproven. Active vitamin Ds are preformed vitamin D hormones, which can lower parathyroid hormone level, but they are unable to correct vitamin D insufficiency. They can also increase serum phosphorus, serum calcium, and FGF23. All of these can lead to risk of vascular calcification. KDIGO in most recent guideline suggested that routine use should be avoided in patients with non-dialysis CKD because of the risk of hypercalcemia. So there is an urgent unmet medical need for safer and more effective therapies for secondary hyperparathyroidism in chronic kidney disease. The question is there an alternative that meets the unmet need? And that's where Rayaldee came into play for management of secondary hyperparathyroidism in stage 3 or 4 chronic kidney disease. What makes Rayaldee unique or different? Rayaldee effectively manages secondary hyperparathyroidism in patients with stage 3 or 4 chronic kidney disease and vitamin D levels less than 30 nanograms. Rayaldee's efficacy is proven in multiple randomized clinical trials where it can increase the serum 25D levels and can reduce PTH. And Rayaldee does it with minimum effects on serum calcium, phosphorus, and FGF23. And that's why it is the only FDA approved extended release vitamin D3 prohormone. It is used once daily at bedtime, where it releases calcifidiol slowly over 12-hour period. Rayaldee's mechanism of action. Rayaldee slowly and reliably increases serum 25D levels to greater than 50, avoiding pharmacologic surges. This 25D is gradually converted into 125D, primarily in the kidneys, but we have learned in last 10-15 years that there are other tissues which are outside the kidney which can take over in patients with chronic kidney disease to make sufficient 125D levels. And this increase in 125Ds result in sustained reduction of 30% or more in the parathyroid hormone levels, which are associated with slower CKD progression. And there are no clinically significant impacts on safety parameters like calcium, phosphorus, and FGF23. Rayaldee has been shown in clinical trials to safely and effectively lower PTH and to be well tolerated. But like any other treatment, there are important considerations to discuss with your doctors. So, what you're seeing on the slide right now is the phase 3 pivotal clinical trial results. This trial composed of double-blinded 26-week studies, two identical trials done under the same umbrella protocols. Patients received either placebo or active treatment with Rayaldee. You could see Both groups started with a 25D level around 19 nanograms per ml. But what you can see in the red is that at the end of the 26-week period, which is the blinded period, 25D levels remained the same in placebo patients, but they rose gradually, predictably in patients who got Rayaldee. And at the end of 26 weeks, the mean 25D levels in patients who received Rayaldee, the levels of 25D were 69 nanograms. At the end of 26 weeks, we provided an open label extension, and the patients who were on the placebo arm were allowed to get onto the active arm, and their 25D levels also rose and reached to about 79 nanograms at the end of 52 weeks. Primary efficacy endpoint of this clinical trial was to demonstrate 30% reduction in PTH levels at the end of assessment period as compared to the baseline. You could see in the blue that Rayaldee nicely lowered the PTH. But more importantly, if you look at the red line on the above part of this slide, it shows the placebo arm, which actually demonstrate that even within this 26-week period, a lot of patients actually had increase in their PTH levels. So it is up to the discretion of the treating physicians at what time they want to start patients' treatment for secondary hyperparathyroidism. One thing is a fact, and that is that as long as the kidney disease is worsening, secondary hyperparathyroidism continues to be there and gets worsened. And so it is up to the clinician to decide when they want to start patients on treatment. But if the patient lives long enough and get to end stage kidney disease, almost every one of them develops secondary hyperparathyroidism. This is a very important post hoc analysis we published in 2019, because we used to get asked this question all the time, that we showed that at the end of assessment period, mean 25D levels were 69 nanograms, but calcium, phosphorus, and FGF23 were unchanged. Obviously, some patients may have higher 25D levels at the end, and some may have lower, as we are only showing mean levels. So we did a quintile analysis to see what happened to calcium, phosphorus, and FGF23 at different levels of attained 25D. So we looked at these parameters at very low 25D levels at the end of assessment period. And on the other hand of the spectrum, we also looked at these parameters, as noted that there was no difference in calcium, phosphorus, and FGF23, even when the 25D level was raised to 92.5 nanograms per ml. As I mentioned, this was published in 2019. The second most intriguing finding from this analysis was that Rayaldee was able to raise 25D level exactly the same in stage 3 CKD as in stage 4 CKD, raised 125D levels and lowered PTH exactly the same, irrespective of stage of CKD. These findings are in contrast to what we know about nutritional vitamin D supplements, which loses efficacy as the CKD advances and the kidney function gets worse. The last, but probably the most critical observation we made in this post hoc analysis was that if you want to see meaningful reduction in PTH of 30%, that was the primary efficacy endpoint of our pivotal clinical trials, or more, and want to keep it sustained, we need to raise the 25D levels to not 30 or 40, but at least 50 or even higher. There is a tendency amongst physicians that when 25D levels get to 30 nanograms, but PTH is still high, they either switch to or add active vitamin D analogs like calcitriol on top of nutritional vitamin D supplements. We showed in previous slides that Rayaldee can raise 25D levels up to 92.5 nanograms per ml without raising calcium, phosphorus, or FGF23. So you may not need two drugs with potential side effects to lower your parathyroid hormone levels. So let's talk about what happens to your kidney function when you can lower PTH by 30% or more and keep it there. This is the post hoc analysis of our pivotal clinical trials we published last year. These 126 patients with CKD stage 3 or 4, SHPT, and vitamin D insufficiency received Rayaldee from the get go till the end of 52 weeks or 1 year. Endpoint again was 30% sustained reduction in PTH in the last 2 quarters of this 1 year treatment period. Out of those 126 participants, 51 had a sustained PTH reduction in both of the last 2 quarters and 75 did not. These are interesting observations. So the group which was able to lower PTH and kept it low for the last 2 consecutive quarters, meaning N of 51, as compared to the group which could not, N of 75, had a mean 25D levels of 90 at the end of 1 year, as compared to the group which could not lower PTH by 30% or more, or is able to keep it lowered for both quarters, has an average 25D level of 72 nanograms per ml. It means that those two groups were significantly different in terms of raising the 25D levels. On the right side of this slide, you could see the group which was able to lower PTH by 30% or more and was able to keep it low. The decline in kidney function over a year was modest, meaning zero point 0.6 cc, as compared to the group which could not lower able to keep it low. The group had a decline in kidney function of 3.2 cc. Huge difference. We discussed earlier the routine practice that patients get started on nutritional vitamin D supplements, and at some point, PTH becomes out of control. So, active vitamin D analogs are added on top of nutritional vitamin D. So, we ran a prospective randomized trial to see if adding active vitamin D to Rayaldee can further lower PTH, and in doing so, active vitamin D analogs can help slowing down the progression of kidney disease further. So this is the schemata of the prospective trial. We had 78 patients who were on Rayaldee for 38 weeks, but their PTH was still above 70 picograms per ml. We randomized them in two groups, one that continued on 60 micrograms of Rayaldee, and in the other group, we added active vitamin D analog, meaning calcitriol or pericalcitrol or doxycalciferol on top of Rayaldee. At baseline, both groups were comparable with regards to calcium, phosphorus, 25D levels, IPTH, EGFR. Patients were treated for 14 weeks. This is a very telling slide. You could see PTH abruptly and precipitously dropped in the group which got active vitamin D analogs. And one would have expected and hoped that lowering of this PTH may have helped stabilizing the kidney function. But what we saw was totally opposite. Kidney function got much worse in the group which got AVD. What is not shown in this slide is that worsening kidney function was accompanied by rise in serum calcium, serum phosphorus, and FGF23. All of them have been known side effects of active vitamin D therapy and may have individually or collectively have contributed to decline in kidney function. Most common side effects of Rayaldee: anemia, infection in nose or throat, increased levels of blood creatinine, shortness of breath, cough, congestive heart failure, constipation. Health issues that occur during a clinical trial are called treatment emergent adverse events. In the clinical trials of Rayaldee, some people received Rayaldee and others received placebo, meaning sugar pill. Among those patients who received Rayaldee, only 5%, 5 out of 100, had to stop treatment because of a TEAE. A similar number of people taking placebo, about 4%, had to stop because of a TEAE. So, how to take Rayaldee? If the parathyroid hormone are above the upper limit of normal, persistently elevated or continuously rising, their 25D levels are less than 30 nanograms per ml, and their serum calcium are less than 9.8 milligrams per deciliter. They should be started on Rayaldee. Patients should take Rayaldee, one capsule by mouth daily at bedtime. Take Rayaldee capsule whole. Do not chew, break, or open. Your doctor may increase the dose based on your body's response. Take Rayaldee exactly as your doctor prescribes. If you miss a dose, do not take an extra dose. Simply take Rayaldee at the next scheduled time. Rayaldee summary. So, Rayaldee effectively and safely controls secondary hyperparathyroidism. Rayaldee can help increase your active vitamin D levels and effectively and safely lower the parathyroid hormone levels in your blood. Treating secondary hyperparathyroidism early can help protect your bones, heart, and overall health, including slowing down progression of kidney disease. Just to remind everyone, Rayaldee is not indicated to slow down CKD progression. Rayaldee use is simple. It's an easy once a day pill that you take at bedtime. If you have any questions, visit our FAQ page at www.royalty.com. If you have questions or you want to report a side effect, you can do so by speaking with your physician. If you have questions regarding the support programs offered by OPCO Connect, you can call the number on the screen. If you have questions regarding Rayaldee or the disease state it is designed to treat, you may contact the Rayaldee clinical pharmacist at OPCO Connect. The number is also on the screen. And you are encouraged to report side effects to the US Food and Drug Administration or safety reporting at opco.com. For more information about Rayaldee, please contact OPCO Medical Information on the number on the screen or the email address, which is also shown on the screen. Thank you so much to the patients who watched this webinar. Thank you, Jerome. Thank you to AAKP.
Dr. Ashfaq, thank you for your insights and presentation and for shedding light on such an important topic. Before you leave, I would like to ask you a few questions submitted by our webinar participants during the registration process. Does secondary hyperthyroidism affect a person's dialysis treatment or transplant readiness?
Jerome, it's a very important question. As I had mentioned in my presentation, secondary hyperparathyroidism is a progressive process. And by the time patients get to end stage kidney disease on dialysis, almost everybody gets that. Why it is important? Because it is going to affect the bones, may lead to bone fractures, bone pain. It also adds to vascular calcifications. Vascular calcifications, to me, are probably one of the most critical side effects of secondary hyperparathyroidism because it can lead to congestive heart failure by causing left ventricular hypertrophy and other forms of cardiovascular disease. Also, secondary hyperparathyroidism for a long time have been implicated in worsening the anemia of end-stage kidney disease. And as you know, most of the patients on dialysis suffer from pruritus, and higher the PTH levels are, higher the phosphorus levels are, there is more itching and pruritus. So all these symptoms get worse when you are on dialysis and stay on dialysis. Now you ask a question about the readiness for the transplant. It has been long known that high PTH levels can actually adversely affect the transplant outcomes. There are a few other things which are really important, and that is that some of those patients' parathyroid glands actually regress after the transplants, but some of them don't. And in those patients, patients continue to develop hypercalcemia, um, and that may pose a lot of problems in the management in post-transplant patients because those patients are much higher risk of developing bone disease, fractures, not just because of the secondary hyperparathyroidism, but also because of some of the medications like steroids they get treated. They are the highest risk patients for bone fractures. So yes, parathyroid hormone levels should go down after transplantation, but doesn't have all of the patients. And as I mentioned, it may impact the life of the graft.
Can you talk a little bit about who's a candidate for Rayaldee? Is it good for all CKD patients with secondary hyperthyroidism?
So we have to be really careful, and I'm speaking as a clinician. We need to prescribe medications for the right patient, for the right indication at the right time. Um, Rayaldee is indicated for patients who have secondary hyperparathyroidism, meaning that their PTH levels are high, they are rising, persistently elevated, they have low vitamin D, they have stage 3 and 4 CKD. These are the candidates for um, Rayaldee treatment. Rayaldee is not indicated for stage 5 CKD or patients who are on dialysis. So we just have to be very mindful of the drug indications.
So, Dr. Ashfaq, another question we received is will Rayaldee get rid of secondary hyperthyroidism or just manage it?
Jerome, it's a really, really important question. I wish I could say that we can actually get rid of secondary hyperparathyroidism using Rayaldee. What is more important is that Rayaldee is a great product which can effectively manage secondary hyperparathyroidism. Now we have to be very mindful, and it's not about Rayaldee; it's about management of secondary hyperparathyroidism. It's that if your PTH levels are not very high, they are very easily manageable. But if the levels become out of control, then it becomes so much difficult to bring them down. And that's why early and effective treatment should be the cornerstone of secondary hyperparathyroidism management.
Another question we received is can Rayaldee be used alongside other secondary hyperthyroidism treatments or medications I'm already on?
I am glad that you asked this question, and we get asked these questions all the time. So, what happens usually is that patients get started on nutritional vitamin D supplements, and when the PTH level is out of control, they either switch to active vitamin D analogs, or uh, active vitamin D analogs are added to nutritional vitamin D supplements. So you are giving two drugs to treat a problem. Rayaldee is very effective in raising 125D by raising 25D levels and thereby lowering the PTH. So there is no reason for patients who have stage 3 or 4 CKD, vitamin D insufficiency, who have secondary hyperparathyroidism should be treated with more than one drug. In addition, if Rayaldee is added to either nutritional vitamin D supplement or active vitamin D analog, it can make side effects worse. It may worsen hypercalcemia, hyperphosphatemia, etc. And as I had shown in my presentation, that Rayaldee was able to raise the 25D level to 92.5, was able to raise the 125D and effectively lower PTH by 30%, and kept it there for the last 2 quarters of 1 year treatment period. There is no reason for any additional products to be given in addition to Rayaldee.
Another question we received is Rayaldee usually covered by insurance or Medicare?
So Rayaldee has a very good coverage, both from the commercial um, insurance perspective as well as the Medicare perspective. And um, just to let you know that we also have a very aggressive and effective patient assistance program for people who are not able to get the medication Rayaldee through either their insurance companies, we provide them with we provide them for free.
Oh, that's great. And what should a person do if their pharmacy doesn't carry the drug?
So we actually have OPCO Hub. Patients can contact OPCO Hub, and they can take care of the process. But Rayaldee is also covered by most of the specialty pharmacies, for example, Walgreens specialty pharmacies, and etc. So there are many ways where Rayaldee can easily be provided to the patients who need it.
Great. Dr. Ashfaq, we appreciate your time today, your expertise, and your commitment to improving care and the quality of life of patients. Thank you again for joining us.
Thank you so much, Jerome, and thank you, AAKP, for this opportunity.
Our next speaker is Lori Single. Lori is a wife, mother, and longtime patient advocate with over 21 years of experience navigating life with chronic kidney disease issues caused by an adverse reaction to prescribed medications. Since 2020, Lori has been managing secondary hyperparathyroidism under the care of her kidney specialist, including treatment with Rayaldee. Balancing her health journey with a busy professional life as an educator in healthcare, Lori is passionate about sharing her story to help other patients feel informed, supported, and empowered. She believes that knowledge and open communication between patients and providers are essential for better outcomes and quality of life. Please welcome Lori Single to the program. Hi, Lori.
Hi, how are you doing today, Jerome?
Very well. Thank you again for joining us. Can you start by sharing a little bit about your kidney disease journey, when you were diagnosed, and how you've managed your condition?
Yes. So, the beginning of having issues with my kidneys was something quite unexpected. I was being followed by another doctor and receiving some medications, and unbeknownst to me, as he continued to increase the medications, I was experiencing really adverse effects from those medications, and did not realize it, pushing myself, going to work, teaching, and doing clinicals at the hospital. Um, it wasn't until the kidney status got to a very significant level that I was made aware of that when I was seen by one of my doctors, who told me that my urine creatinine levels, my BUN and creatinine levels, were, quote, off the charts, which was surprising to me because I did not have kidney problems. So I think you kind of go through a lot of the 5 stages: shock, anger, denial, bargaining, acceptance. I couldn't believe that this was happening to me. This was back in 2004. It was right around Christmas time. So I went to see a renal specialist, and because of other health problems that I had, he wanted to rule out different causes that might have been, had not understanding at the time that it was the medication that had caused the problems. And so he went through some tests, and then I ended up having a renal biopsy. And when he looked at all the slides, he discovered that there was a significant amount of intrarenal damage due to a classification of medicines called NSAIDs. And so, because of that, we began a path of trying to see what he calls, what can we preserve and conserve of my kidney function. And I have to tell you, I've been followed by this renal specialist for 21 years. He's remarkable. We've had ups and downs with that. Trying to push past problems with low blood counts and fatigue and concerns about what's happening with my body. It's very hard when you're in the healthcare field. You actually understand the anatomy, physiology, and then the pathophysiology of what's happening. So it's not that you can ignore it. But I believe it was about, 2023, he picked up that I had elevated levels of the calcium and then checked the parathyroid. And that's when he picked up the secondary hyperparathyroidism in me and started on the Rayaldee.
Yeah. Before we get to your treatment, how has living with CKD affected your day-to-day life, both physically and emotionally?
Emotionally, there is always a hidden toll going on in the background, at least for me as a healthcare professional. I'm cognizant of it. I make efforts to kind of push it out of my mind and just move on with my life. I have made changes in my life absolutely following what the doctor had told me. NSAIDs are absolutely forbidden, or any kind of contrast dye, so I have to be careful of that. I'm a big water drinker now. I always was drinking water, but I really drink a lot of water now. And I kind of pay attention to things that I'm doing, making sure that the program that he's given for me to follow to try and preserve as much of my kidney function as possible includes a number of different categories of medications. So you have to coordinate that with your daily life and with travel, making sure that you have everything. I speak with my doctor when I have concerns, because although I have education, he obviously has more than I do. And so I need to talk with him when I have a concern, because I don't know if it's something that is significant or I'm just worried about it. Um, uh, Thinking about how one lives their life with chronic kidney disease, you pay attention to what your body's telling you. So with my life, if I am fatigued, I go to bed. If it's early, that's fine. Then I need to rest, because obviously my body's telling me I need to do that. Um, I have changed the way I eat, much more what I call God's food in the original wrapper. So as I will tell my students, an apple's wonderful. The fried apple pie at McDonald's not so good. Walk away from the package. Yeah, a lot of processed foods are very high in sodium, which is very bad for kidney patients. And I also need to watch with the calories and fat intake. At one point, I was put on steroids as an anti-inflammatory protocol, and because of that, you gain a lot of weight. But I've lost that weight and helped to maintain a healthier weight and more active style. Um, Making sure that my family understands my journey has helped a lot, because at first my kids did not understand, and I did a pretty good job of hiding it from them, but they're adults now, and so I want to make sure they understand where I am in my journey with kidney disease and the steps that I'm taking to try and protect what I have left.
Can you talk about when you first heard the term secondary hyperparathyroidism when it comes to your health, and how was it explained to you?
Uh, it kind of popped up out of nowhere to me. The doctor, I went for a doctor's appointment, and of course he's been tracking my labs for years and years, and he started noticing an increase with the calcium levels. So he checked the parathyroid, and it was quite high. So we had a conversation, and I think what's different for me as a patient is that I have a basic understanding of endocrine system and functioning. I'm not that familiar with the secondary hyperparathyroidism in renal problems, so that was a new thing for me to add on to my plate. Of course, I was concerned about it because I understand the complications that come from the elevated levels of calcium. So when he suggested a treatment regimen, I follow what he says. He's board certified. He knows exactly what he's doing. He's been taking care of me for 21 years and helped to maintain a better level of life for me. So I'm following what he says. So when he suggested Rayaldee, I said, okay, let's add this into the mix, and we're gonna follow that plan.
From my understanding, secondary hyperparathyroidism is like, high cholesterol. And though bad things are happening in the body, early earlier in the course of the disease, it remains silent. So, did you have any
Mhm.
symptoms?
No, I
Um,
just, who knows? I mean, I lovingly refer to myself as a train wreck. I have multiple health problems going on in addition to the kidney disease. So when I pick up symptom A or symptom B, then I have to start figuring out, is that because of health problem A, B, C, or D, or this? And so I rely a lot on my renal specialist to help me to wade through that, because no, I did not realize that the levels were, when I noticed my labs had the calcium levels starting to rise, I was trying to pay attention to my diet to see what I was doing or not doing that would affect that, and not realizing that there was an underlying problem going on that he picked up on.
yeah, can you talk a little bit more about when you first started using Rayaldee? Uh, what who told you about it? What led you to start using it?
Okay. The renal specialist that's been following me for 21 years is the director of the bus. He's the one that he drives my plan. Now, I think it's very important for patients to understand that no matter what their education level is, that they should have conversations with their healthcare provider, and they need to explain things in terms that they understand. Now, myself and my doctor, we talk at a higher level because I'm in healthcare, but that doesn't take away, if I don't understand something, he will break it down into pieces so that I can get the clear steps of what's going on. And so he explained the Rayaldee. He also explained that I had been taking some vitamin D supplementation that needed to stop, because you're not supposed to do that when you're taking the Rayaldee. So he started that, and then what he does is he does a series of labs to monitor the levels to see how things are going on the medication.
Now, were you being treated with something else and then switched to Rayaldee?
For the secondary hyperparathyroidism, no,
Yes.
no, Rayaldee is the only drug that we've used. He said that was the drug of choice. Um, he's quite brilliant, very well read, and he's up to date with research and evidence based care. So he's always, when I say he's on the cutting edge of whatever happens to be going on. So when he said Rayaldee was the best product, I absolutely agreed.
Yeah. And what has your experience been like since starting Rayaldee? Have you noticed any improvements or changes?
Well, my labs are better, so he's happy about that. The calcium levels have gone down, and he's been watching the parathyroid levels, so that everything needs to be balanced, right? So we don't need a super high parathyroid hormone level going out. So he's watching those, so those are going where he wants them to go. In the beginning, I I did not even notice that there was anything going on. I did notice subsequently that there was a drop in my hemoglobin and hematocrit, so my blood count went down a little. I'm also on other medicines that could cause a drop in the blood count, so I'm trying to separate the weeds from the grass of which one's causing which or whatever. But my blood count has pretty much stabilized. I take the medicine every night. I don't feel any side effects from it. Um, I believe that if you were to ask me to look back over the past couple years, I feel like I'm less tired, and I have less fatigue and more energy now. I don't know if that's just because I'm feeling better, or things are balancing out and my body's getting back into to balance. I have a very
Yeah,
busy life.
yeah, sounds like it. Is there something you wish you had known earlier about secondary hyperparathyroidism and the importance of managing the condition?
Chronic kidney disease has so many possible changes that can happen because of it. Okay. You don't make enough erythropoietin, so your red blood cell count goes down. So is that because of this, or is it because of that? Then you have to watch the calcium levels. Is it because of the diet, or is it because you're not producing it, or you're not turning it into active levels? I think it would be helpful for patients with chronic kidney disease to have just the top complications that come from that kind of discussed or laid out, maybe a pamphlet or something, just to keep it fresh in their mind. I mean, everybody talks about, are you keeping your hemoglobin A1C low? Are you keeping your cholesterol level low? Are you following the blood pressure protocols? Are you keeping the water there? Are you monitoring your sodium intake? I mean, there's a lot going on for chronic kidney disease. So ask if secondary hyperparathyroidism was anywhere on my scope at the time. No, it was not. Should I've had maybe a pamphlet that let me know that that's something to keep an eye on? Maybe. But the other piece you need to understand is I went from a crisis point 21 years ago at how old was I? Uh, 44 at the time with young children. This was a crisis. I mean, I thought I was on a downward slope heading to dialysis and death. I mean, it was very, very bad. So just to come out of that and to level out. And so what my renal doctor has talked about is that my levels went down a little bit and then I kind of balanced out and I've been staying steady. And he says we're kind of in uncharted territory. So my belief, my faith tells me that I'm being given things to help me, which is making a better quality of life for me. And by taking Rayaldee and correcting a problem that could have really significant consequences, that only adds to the more positive outlook on my life and the quality of life that I have.
What advice would you give to other kidney patients who might be dealing with secondary hyperparathyroidism? Would you suggest to your fellow kidney warriors that they check for, the condition early?
I believe that if you have chronic kidney disease, if you're being followed by a quality healthcare provider who specializes in kidney disease, okay, general practitioners don't follow this. That's the whole reason I got into this problem in the first place, is because the doctors were giving me massive amounts of NSAIDs, burning out my kidneys, and nobody was watching the labs. Nobody was watching the side effects that come from that. So what I have said, um, I I have been teaching patients for 42 years. Okay. You need to be active in your own health care. You need to talk with the doctor. And if that means that they can have a little notebook where they can track their labs and be able to see that, or they can talk with the doctor, because my doctor has kept all the labs running constantly all this time so he can watch for patterns and whether it's a bump that just goes up and comes back down, or we're seeing a trend where it's starting to go up. I've always believed that a patient, we call it in nursing the health belief model. The more a patient feels that they have some power over their health and being able to keep their health, the better they do. When a patient feels helpless and hopeless, that spirals very badly down. So if you have somebody who has chronic kidney disease, like I said, in addition to worrying about diabetes and blood pressure and salt intake and cholesterol levels and water intake and their weight, yes, but I would put that in a little piece. I would add that little piece in there to keep track of that, because obviously it's better to handle this sooner and get on medications that will address it than later, because sometimes you can't fix what happens.
Thank you, Lori, for sharing part of your kidney journey. We appreciate you being with us today.
Happy to be here. I'm happy to help other patients. I've always felt that education is a great equalizer. So the more education and information a patient has, the more they can partner with their healthcare provider. Thank you very much.
If anyone watching has additional questions for our speakers or about today's webinar that we were unable to get to, please email us at info@aakp.org, noting the webinar title in the email subject line. In closing, if you are not already a member of AAKP, we encourage you to join. AAKP offers free membership to patients and their family members, as well as living kidney donors. To become a free member, join online at aakp.org/join or by phone at 1-800-749-2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified about all of AAKP's upcoming events, the latest in our educational program series, and when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the independent patient voice and change status quo kidney care. You will also receive a digital subscription to our bi-monthly magazine, AAKP Renal Life, and can select to receive any of our 5 different electronic newsletters, all for just signing up. We also invite you to check out our blog and read some great articles and patient profile stories, and follow us on social media for all the latest news and to keep up on what's trending. AAKP is dedicated to helping kidney patients across the disease spectrum understand their condition and take control of their healthcare. We are proud to offer a variety of resources for both patients and care partners. By visiting our website at aakp.org and clicking on the AAKP Store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download free of charge, including titles such as the AAKP Pocket Guide to Managing Phosphorus or the AAKP Nutrition Guide. Looking ahead, we are excited to announce the AAKP All Kidney Policy is Local campaign. As members of Congress return home to their summer recess, now is the time to speak up and remind them that kidney policy decisions made in Washington have real consequences for people in their own communities. Join us as we take action, raise our voices, and make kidney policy personal. Contact me, Jerome Bailey, at jbailey@aakp.org to learn how to get involved. We're pleased to announce the 50th annual AAKP National Patient Meeting is taking place October 3rd through the 5th, 2025 in Fort Worth, Texas. This year's event will be a hybrid event with in-person and virtual options for attendees. Join us as we celebrate this event's golden anniversary. Visit the AAKP website to register and to book your hotel room under the AAKP discounted rate while rooms are still available. Additionally, don't forget to visit our AAKP On Demand webpage at bit.ly/AAKP On Demand to watch inspiring presentations from 2024 and upcoming 2025 events, and explore even more great educational content on our AAKP YouTube channel at bit.ly/AAKP YouTube. We would like to extend a heartfelt thank you to our webinar speakers, Dr. Akhtar Ashfaq and Lori Single, for graciously participating in today's HealthLine Innovator event. Their expertise and insights greatly enriched the discussion and provided valuable information. We also want to express our gratitude to OPKO Renal, a division of OPKO Pharmaceuticals, for sponsoring today's webinar. Thank you for joining us. We look forward to you joining us for another great HealthLine event.